Hi, folks. I'm Adam Mariano, President and GM of Healthcare for LexisNexis Risk Solutions, and welcome back to Healthcare DataWake. This is a podcast where we talk about how data can be used to improve healthcare outcomes, efficiency, and equity, and also about all the places where healthcare data runoff and exhaust, data that's often lost as part of the process in which we treat patients, we can engage consumers about their healthcare. We talk about clinical research and all the other facets of healthcare is often wasted or not utilized in a way that really can make an impact and a difference. And so how do we better track patients like boats on the ocean in their wakes through their entire healthcare journey? My guest today is someone who is helping to drive healthcare equity from the top down. Mary Stutts is the CEO of the Healthcare Businesswomen Association. And if you're unfamiliar with that association, it's a global organization focused on three critical things: achieving gender parity in leadership positions, providing equitable practices that enable organizations to realize the full potential of women everywhere, and then facilitating career and business connections to accelerate advancement for women. And so we're really happy to have you here today. Welcome. Thanks for coming to talk to us.
Yeah, I'm glad to be here. Excited to have the conversation, and thank you for the invitation.
Thank you. So we wanted to talk to you today about really a bunch of things, but starting to focus on equity, representation, healthcare leadership, and about why top-down representation is so important relative to the rest of things that go on in healthcare. And you're sort of at the center point of that in the ecosystem. So maybe we could start there. So can you talk to us a little bit about why we really need more equitable representation in healthcare leadership, whether that's health systems, health tech companies, pharma, but what really is the critical need there as a whole for the U.S.?
Yeah, certainly when you look at the healthcare system overall, one of the things we focus on quite a bit, we are a 50-year-old organization started by 5 women, almost 50 years ago. We're in 80 countries. Our overarching mission is to further the advancement and impact of women in the business of healthcare. And the reason that's so important is because the majority of the healthcare workforce is female. Almost 90% here in the US, if you count public health workers. It's about 70% in Europe, and in countries like India, it's about 65%. So clearly, if women are the majority of the healthcare workforce, then women need to be involved in the decision making. And what we're seeing in healthcare is while women are very active and they are the majority of the healthcare workforce, as you go further up the ladder, women are not there. It's more male dominated. And that's a problem because we need women in decision-making roles. If women are not in these decision-making roles at these higher levels, then the best decisions just won't always be made. And even when you look at health equity, we are seeing that the majority of the health equity innovation is coming from women. And the reason that innovation is coming more from women is because they have worked in healthcare their entire careers, entry level, and worked their way up. They know what needs to happen. They have a pretty good sense. They know what the challenges are and they have a good idea of the solutions. And that's why they need to be at the decision-making table. And I believe that the reason we are so far behind when you look at health equity, even when you look at women's health equity, we're so far behind because women have not been involved in a lot of these decisions, which is why, as you probably heard earlier this year, McKinsey issued the report on the $1 trillion health gap between women's health and men's health. And a lot of that is because women have not been involved in those key decision-making roles, even at the higher levels. And these are things we are really drawing attention to with the HBA, with our data, with our HBA think tank now. We're doing surveys and data and really drawing attention to not only the challenges, but possible solutions.
Well, and you hit on a bunch of points there, but I think all of them focus around the fact that by not having women at the table, by not having women involved in innovation, by not having women involved in leadership roles or being represented, you end up introducing a bunch of unintentional bias. And we'll call it unintentional, but I think with such a long history of it, it starts to feel like it can't
Yeah.
You have to stop saying unintentional. The industry is designed and set up this way where we have a structural bias against parties, and it's something that we have to take advanced steps to resolve.
Right.
But I think one of the critical issues that we see, and you see this in healthcare access, you see it in research, is and you pointed to this from McKinsey and others, right? Which is that when you introduce that bias, we're not serving those populations well, both from a treatment perspective or an engagement perspective. So when you don't represent women in research populations, cardiovascular drugs are the one that everybody always points to for years, right? It's
Yeah.
essentially a white male population that we do research on, and we have a
Right.
huge risk with especially Black and brown women in
Mhm.
healthcare for heart disease that goes undetected, late detection, undertreated. And again, it's the bias. There's a bias in diagnosis. There's a bias in treatment and follow up, but also realistically on recruiting patients even into clinical studies. You may never get processed and be integrated into that study, and therefore won't be part of the population that should be reviewed. So you got all the same problems.
Yeah, the clinical research piece, I would say, is probably the biggest factor. I actually did the first diversity in clinical trials initiative when I was at Genentech in the mid 2000s, and it's sad to say that a lot of the things that we found then we are still seeing now. So what we found
Mhm.
when we did that very extensive data with Baylor University and the Cancer Research Organization and the Chronic Disease Organization, it was a big partnership that we did. But what we found was that women, no matter what their race or ethnicity, women and people of color were not being offered the option to participate in clinical trials. And what we also found was when the newest, most innovative therapies were launched, same group, women and people of color were not being offered the option to go on those new therapies. And we are still seeing that today. There's been a little bit improvement with women when you look at things that are specifically for women. There are more therapies out there that are specifically for women, but otherwise, when it comes to all these other disease states, you're still not seeing it. So the that and it's about options. And this is why, when I talk to folks, and as you know, I did a lot of health equity work before I even came to um, HBA. I was Stanford Health Care first global chief of inclusion and health equity. First time they ever created that role. And so we were looking at health equity then, and then also with real chemistry, looking at it then. So what we found is this lack of giving people their options is how I've tried to narrow it down,
Yeah.
because we tell people, oh, you tell patients, oh, you got to advocate for yourself. The average
Yeah.
person doesn't know what that means.
They don't
We,
understand necessarily what even options are on the table for them. And you pointed this out. It's always this misinterpretation that women and minorities don't want to participate in clinical studies. But to your point, what we find in study after study is they're just not being offered the opportunity. When
they're
offered,
not
they
being
participate at the same levels as all other
taught.
populations.
And we found that when you look at, even especially when you look at African Americans, when you explain to them about the benefit of the research to their children and
Mhm.
families and that longer term impact, they are actually more prone to do it. People understand that now. And even when you look at people of where English is their second language, of other nationalities, specifically like Spanish speaking people. I mean, I was doing a talk at an organization in San Diego at Biocom, and talked to a resident there who talked about, residents follow the physicians around, and they don't really get involved in the conversation because they're observing, because they're being trained. But he shared about being in an exam room with a physician and having a male patient, and when they were done, the resident, when they came out, said, that man probably was eligible for our clinical trial. Why didn't you offer that to him? Physician says, oh, he doesn't speak English. I don't have time to
That
deal
can't
with
be
that.
the answer, right?
That can't be the answer,
Yeah,
but this is reality why
it
we're
is.
not
It
seeing
is.
this inclusion in health equity. And as a result of that, we are not seeing similar results. And this is why having data, making sure we're doubling down on that and drawing attention to those areas where we need to make improvements is critical. And certainly, um, pointing out to people why some of these things are happening, why these discrepancies and disparities are there. We know that maternal and infant morbidity is like huge. Number one, my first child died of a crib death at 2 months old.
That's
Me and my
terrible.
second child both almost died in the hospital, in a top women's hospital. Um, of placenta previa because they just stuck me in a room and didn't listen. And this is the main point for women, all women,
Mhm.
but certainly women of color and people of color. The physician didn't listen to me. A lot of times, people say what their symptoms are or whatever, but the physician doesn't take them seriously. And by the time they do, the disease has progressed so much that they have these worse outcomes. So the time to diagnosis is the biggest health equity challenge that we've got to improve. And you cannot put all that blame on the patient. A
No,
big part
you
of it,
can't.
yeah.
And to your point, and probably for our listeners, we should probably do a little explaining because you and I just covered 100 years of history in probably 3 minutes. Um, there's this legacy of folks from our community, the Black and Brown community, folks from the side of women having been either excluded from care, gotten differential care, um, been experimented on in a proven way, right? That we've got documented cases of that across history. I talk about people in my family. I have an aunt who does not trust the healthcare system at all.
Mhm.
Grew up in civil rights era and has terrible experiences in her healthcare delivery, and that has biased her
Yep.
interaction to the system. And she was also not listened to for care. And I'm a nurse. It's where I got my start in my career, and
Mhm.
I watched it firsthand in care delivery, where you might be following behind a doctor or a resident or an intern who came out of school with the same biased ideology, wasn't exposed to a broader sense, came with their own biases from their community, and wasn't listening to people about pain control, wasn't listening to people about, to your point, symptoms that were clearly not aligned to a normal delivery, and that would have been received perhaps from a patient with different skin color or a man versus a woman. And we
Yep.
need to burn that impulse out of the system, right? That has to come
Mhm.
out of healthcare training. It has to come out of early practice, but also needs to be reinforced that this thing really exists. We all walk around, regardless of who you are and where you come from, with your own internal biases.
Yeah.
But
Yeah.
intentionally breaking that cycle and teaching, hey, you come with bias no matter where you're born and who you're born to. How do you break that so that you don't show up in a critical moment and not offer the assistance to somebody that really needs it, or be blind to the fact that there's a pattern you're not recognizing because it's non-standard, right? And that
Yeah. That's
non-standard
why.
presentation is a killer, right? It's one of the ones that
Yes.
causes most of the problems.
Yeah. That's why one of the things we were focusing on quite a bit with our corporate partners, we have over almost 190 corporate partners in the HBA. And one of the things we're focusing on with them is the fact that the workforces, our healthcare workforces, have to be representative of the patient population. I mean, let's face it, people most trust people who look like them.
Hmm.
All of us. That is an inherent bias. It's not necessarily wrong. It just is what it is.
It
People
is.
most trust people who look like them. So it's going to be very important for us to have workforces that are representative of the patient populations. And we also have to make sure that people understand about cultural humility and listening to people and respecting people. Clinical trial coordinators who make the decision on who gets to be in the trial, the data shows 71% of clinical trial coordinators are not people of color, they are white. So, and their biases kick in right away when you walk in the door, like you said.
Since we're on the clinical trials recruitment and the life cycle stuff. Is there a spot in the life cycle you think has the most opportunity? Early clinical research, we know just we have to change recruiting, but is there any other spot beyond that that you think would be a really easy place for us to engage in uplift?
Yeah, I think the marketing piece. I mean, when I was doing the consulting work at Real Chemistry and working with all these different companies after they, as we talked about, after the FDA has approved the drug and you're getting ready to market it, and it's just mind-boggling to me how people, I got to the point where I stopped using the word access because every time as we were looking at here's this great new therapy and we need to get it on the market and I would say, what are you doing about access? Immediately what I would hear is, oh yeah, we're going to do something for people on Medicaid. And it got to the point where some people I had to say, do I look like I'm on Medicaid? I every Black and brown person is not on Medicaid. I was speaking to the fact that the newest, most innovative therapies are not even being offered to diverse populations, and they immediately are going to ability to afford it.
Yeah,
And
ability
I
to
had
pay,
to
right?
say,
Yeah.
yeah, and I had to say, Black and brown people have jobs. We're insured. We can pay the copay, all these things. And I literally had some people like, oh, hadn't thought about that. So can you imagine how much money is being left on the table now? And I'm a dollars and cents person. The business case for inclusion, the business case for inclusive marketing and making sure that you're reaching everyone who should be on your therapy is huge. And as an industry, we are leaving billions of dollars on the table because we're not doing a good enough job of reaching all of the patients who should be on your therapy.
And you hit on two critical things there. So one is none of our populations are monolithic, right?
Right.
So you and I, both Black folks, come from very different arcs. We could sit down, probably find lots and lots of common crossover, but born in different places, raised at different times, we're going to have very different approaches to healthcare. Yes. You and I are probably closer than most because we have the same ideology about what's broken. But yes. The reality is when you treat Black or brown populations or Latino Hispanic populations like a monolith, you get the kind of effects we see, which is you're focused on ability to pay. Well, that's a ridiculous misnomer. If you look at the population for Medicaid for Black and brown folks is 5%. It's nowhere near the population, and it's actually relatively low distribution, and it's clustered in urban areas and in the South, right? And so, but looking at that and then thinking about, okay, well, I need a full distribution for access, so we should make sure that things are accessible to people who are on Medicaid, but we should also make sure that they're accessible to people who may not have Medicaid support and are in a private pay commercial scenario and may not have a drug approved. There's also the idea around access. So if you're never going to community health systems from a geography perspective to do clinical research, you're not reaching populations that aren't clustered around high-end tier 1 research centers. Like those things seem like opportunity.
Yeah, I'm glad you mentioned that because that was the third thing we found out when we did that diversity in clinical trials initiative at Genentech, which was that the diverse physicians, even if they were specialists, because we know primary care docs aren't typically selected, although we should look at that too. But even the diverse physicians were not being offered the option to be an investigator in the trials. And so that is also a big problem where the biases are impacting us. And the other thing I want to add, we're talking specifically about people of color, but again, the data shows this applies to women too.
It applies to women for sure, 100%.
Regardless of their ethnicity. Yes. So it's women and people of color that are having these challenges, which is why there's that huge health gap for women overall, as well as for people of color.
100%. So, Mary, you and I are going to solve all the world's problems.
Yeah, right.
That's awesome. I want to thank you, Mary, for coming to visit. I'll remind folks that my guest is Mary Stutts, who's the CEO of the Healthcare Businesswomen's Association. If you haven't been to their website, go. It's hbanet.org. That's right, Mary, correct?
Yes, that's it.
if you're a woman in the healthcare business and you're looking to connect with great folks, if you're someone who's supporting, like all of us should, women in the healthcare business and leadership and equity, please go check out all the programs there. And Mary, thank you for your time today and for spending an hour with me.
You are welcome. It was my pleasure.